Hi, everybody, and welcome to today's PrEP webinar. My name is Dawn Reinhardt-Wood, and I am one of the faculty with the Rutgers Institute for Inpatient Psychiatric Rehabilitation, formerly known as SPRE. Today, we have Reverend Mark Stevens from Ancora Psychiatric Hospital, and he's going to be giving us a talk about spirituality in recovery from grief and trauma. And this presentation is done in partnership with New Jersey Department of Behavioral Health Services. It is an interactive training, and we encourage you to ask questions and participate throughout this session. A recording of the webinar will be made available after the presentation on the Rutgers IPR website, and that is listed there below. And also, as we progress through the webinar, my colleague Tom will post the link in the chat for you.
Yep.
As a disclaimer, the Psychiatric Rehabilitation Educational Program is an online forum of a variety of topics relevant to the state psychiatric hospital staff. While Rutgers and DBHS are co-sponsors of this program, the PrEP webinars are peer presented, and as such, content is independently developed by the presenter each month. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. It's a mouthful to say, please don't sue. Not that we would make you. Also, please note this session is being recorded, and a recording of this webinar will be available on our website and Rutgers IPR YouTube channel at a later date. So I had a very hard time fitting all of our presenters' qualifications on the slide, but I really thought that his experience is so impressive that I wanted to highlight all that he has done, not only in his ministerial work, but also in the world of mental health and social services. So Reverend Stevens has been a minister for over 25 years. He holds multiple certifications, not only in his chaplaincy world, but also or in the world of the church, but also in the community, in crisis response, in domestic violence response, and he is also a fellow psychiatric rehabilitation practitioner, which many of us at Rutgers Department of Psych Rehab also are. So this is a wonderful blending of the world of spirituality and religion with mental health treatment and disaster response. So he's really poised to speak well on this topic. So in this webinar, Reverend Stevens will share his knowledge from many years of experience as a trauma and mental health chaplain, including techniques that have helped him bring comfort to and guide people through some of the most horrific life experiences. These tips will give both clinical and pastoral professions helpful guidance in serving those individuals in our care who may be grieving or experiencing trauma. And I'm just going to read through the learning objectives before I turn it over to Reverend Stevens. So by the end of this webinar, we hope that you'll understand the grieving process, understand the role of chaplains in recovery from grief and trauma, identify situations in which chaplaincy services may be helpful to the individuals you serve, and identify helpful approaches to addressing grief and trauma. With that, I want to turn it over to Reverend Stevens.
Hello, my name is Mark Stevens, and I would like to share some of my life experience and knowledge about helping traumatized people. I think sometimes people have a tendency to think that chaplains just talk about God and share religious tidbits throughout the day, but it's a lot more than that. In a lot of ways, we're clinical as well as spiritual. We have to recognize certain traits in the patients that we encounter. I deal with patients that are schizophrenic, bipolar, PTSD, you name it. I encounter these different types of patients. So you have to really be empathetic towards the clients that you work with. Also, I work as a trauma hospital chaplain in Camden, and a lot of times I have to deal with people that have been severely traumatized by either their own injuries or their own diseases or family members. And it's not easy. I would recommend that if you want to become a chaplain, you really think seriously about it, because it's definitely not something that any and everybody will want to do. So we're going to talk a little bit about losses associated with grief. And a lot of times when we talk about trauma, uh, trauma and grief go hand in hand. Uh, a lot of times when you're helping somebody that's going through a trauma or going through a period of grief, um, you have to really approach them with love and be very observant. Don't be judgmental. Don't try to give them answers to solve their problems, because you don't have the answer. Um, so you have to remember that uh, a lot of things can cause grief, and a lot of things can cause trauma. A lot of times we talk about grief, we usually associate that with just the death of a loved one, but sometimes when you've gotten a bad diagnosis from a doctor, you've been told you got cancer or you're gonna die. That can cause severe trauma. If it's your spouse that gets the bad news, that can cause severe trauma and grief. And as you see on the slide, job loss, life before illness. A lot of times when a person gets diagnosed with a chronic illness, that's totally going to change their life. They may lose their job, they may lose their marriage, they may lose influence, whatever. So as a chaplain or a psych counselor, you have to be aware of these things, and also put yourself in their shoes. Don't judge them. Don't consider, maybe what they're going through is not something that you would be upset about, but put yourself in their shoes. And that's something that we have to learn how to do. And of course, love. You've got to love what you do, and also love the people that you're assisting. That's the key. Love is the key. If you don't love what you're doing, get out of it. I've seen chaplains get burnt out, and they don't love their job anymore. Leave. When you stop loving it, you're not going to be effective anymore. Next slide. Okay, the grieving process. A lot of times, I know when I was in training, they talked about that 5 stages of grief. Unbelief, anger, depression. These are different stages of the grief process, but they don't always come the same way. I've had to deal with patients that lost a child, and sometimes the stages of grief don't come in the order that they're given. Sometimes anger is the first thing that you see. I remember I had a man that lost his 5-year-old child from an asthma attack, and he punched a hole in the wall in the emergency waiting room. And those are some pretty thick walls, but he was that upset. And they called security, and I had to kind of back security off, because I had to remind them, if that was your son, how would you react? So I got him to calm down, took a walk with him. But these are all things that are part of the grieving process: anger, unbelief. Like usually people say, "I can't believe that my wife is dead." Those are all a part of the grieving process. Acceptance is the last part of the grieving process, but that's a long way off. And I think sometimes you never really truly accept it, but you learn to live with the loss. You learn to live with the loss. Also, it says not orderly or linear. That's what I mean. It doesn't come in the orders that they're given. It may come differently. I love this: refrain from quoting religious texts. I remember I had a situation when I first became a chaplain at Cooper Hospital. A lady lost her baby. Baby was 6 months old, and it was just a crib death. Nothing shady, nothing, suspect. The baby just died. And when she got off work and came to the hospital, one of the nurses put her hand on her shoulder and started quoting Bible verses to her. So I had to put my hand on the nurse's shoulder and kind of walk her away, because at the time that lady wasn't trying to hear a sermon. She needed a hug. She needed somebody to listen to her. And she was really upset. I mean, she was screaming and hollering, "God, why would you do this to me?" So that's not the time to start quoting scriptures to people. Prioritize basic needs. A basic need might be a hug. Basic need might be to listen to them vent, to scream, to holler, to cry. You have to learn how not to be shocked by what people say. You know, I've seen very religious people curse God when they experience a loss. I never forget. I had a friend of mine. She was a Christian. She loved the Lord and everything. And her son died in a gunshot situation. He got shot, and she got on her knees and started screaming at God. God, why would you do this? Why would you allow my son to die? She's screaming at God. Don't act like, don't act shocked. I got on the ground with her. I put my arm around her, let her cry. And the last thing, be patient. Don't expect somebody to get over it in a matter of minutes. A lot of times when they call for a chaplain, the doctors will call for chaplains because maybe the people are acting real loud and screaming. And they expect the chaplain to come in and wave his hand. Everybody stops crying. It doesn't work like that. A lot of times when I'm with a family that's grieving, I get coffee for them. I get water for them. I'll sit and listen to them. And if they want to be alone, I'll leave them alone. So don't ever try to force yourself on people. Maybe they want to be alone. I find a lot of times that men and women grieve differently. Not all the time, but a lot of times. I find that with men a lot of times want to be alone. I've been with fathers that lost their sons and daughters, and a lot of times they'll walk away from the crowd and they'll go in the lobby or they'll walk outside. So I noticed this is different. So respect people's space. If they want to be alone, let them be alone. But if they want company, they want somebody to sit there and be attentive. Listen, don't preach to them. Don't tell them how they should feel. Just, be there for them. The ministry of presence is what we call it. Being present is a ministry. Being present is important because sometimes when a person is going through extreme grief and trauma, that's the most alone that they'll ever feel. So just having somebody there until the family gets there or until maybe their clergy gets there, just be there with that person. Next slide. Okay, thou shalt not say or do these things. Don't say things like God is too wise to make a mistake. Oh, praise God, they were saved, or they were Christians, they love God. Don't say these cliche things. For one thing, as far as God is concerned, we don't know why that person died. We don't know what God's plan was for that person's life was. And depending upon how they died, it could have been a gunshot victim. It could have been an accident. It could have been a whatever. You don't know. So don't try to get into the realm of trying to figure out why things happen. Avoid that kind of conversation. All right. Okay. Don't ever start a conversation when a person is traumatized or grieving like what you should feel. Fill in the blank. No, you don't know how that person's going to feel or how they should feel. I remember one time I had a lady, she lost her husband and she had lupus, a very bad case of lupus. And he worked 2 jobs, paid the bills, took care of her, took care of the kids. I mean, he was like a one-man army. And so it was at the end of his life, they had to make a decision whether they were going to put him on hospice. And the nurses and the doctors were really trying to force her to make a decision. So they called me. And I looked at the doctor and said, I can't force her to make this decision. She has to make this on her own. Also, he is her sole provider. You're asking this woman basically to give consent to let this man die. And she's thinking about how are my bills going to get paid? Who's going to pay the mortgage? How's the food going to get on the table? So you have to be really careful when you approach people with things of this nature, and whatever you do, don't try to minimize the pain. All right. I'd say another one, don't ever say to a person that's suffering or traumatized, I know how you feel. No, you don't know how they feel. You may have experienced some of the same things, but you don't know how they feel. Okay. All right. On personalization, overstaying your welcome. If they want to be alone, like I said before, let them be alone. Some people like to be alone when they're going through trauma or rough situations. Just tell them, I'm out in the hall if you need me. Give me your card. Here's my phone number. Give me a call. I'll be right back as soon as you want, if you need me. But don't ever force yourself on people, if they're going through a traumatic or grieving situation. All right. Thank you. Grief-related emotions and behaviors. Guilt. A lot of times when people, especially when it's a child involved, whenever there's a death of a child, a lot of times the parents, whether they were responsible for the child's death or not, a lot of times they blame themselves. So, you can't try and talk them out of feeling that way, but they're going to feel the way they're going to feel. Okay. Anger, that's a big one. People get angry when they experience grief and experience hardships, so don't try to tell them not to feel the way they feel. I've seen people scream, punch walls. I've seen people punch people. So be careful. Just, be there, but, don't get too far into people's space, especially when they're angry, and they're wailing, cursing, staffing God. I never forget one time I had a lady, she punched me. Her child died, and I had on my clergy shirt. And when I walked in the room, she saw me and punched me and said, "Why did God take my baby?" And I just stood there and let her hit me in the chest. Did it feel good? No, I didn't like getting hit in the chest, but I had to let that lady vent. All right. Next slide. All right. Grief, well, I kind of touched on this earlier. Grief is unique, but it's universal. All of us at some point in our life are going to feel grief. We're going to feel anxiety. We're going to feel pain. So, what I say, like I said earlier, don't try to put yourself in that person, or try to diminish that person's grief. I've seen people that went through some horrific things, and to say, I understand how you feel, no, you would never understand how they feel, because it's their tragedy, it's their grief, it was their trauma. Let them, marinate in how they're going to get through it. Best thing you can do is be there. The ministry of presence, best thing you can do is be there. Next slide. What to say, okay? Address the situation. A lot of times we're afraid to use the D word. I call it death, the D word. No, say it's okay to say dead, death, died. That's what happened, okay? I heard your father died. I heard your husband died. Don't be afraid to use that word, okay? Express concern. I'm sorry to hear that they died. A lot of times we try to soften the blow by saying, they went to a new world. Or no, just it's okay to say that they died, because that's the reality of the situation. Offer support. Now this is a big one for chaplains. Are you hungry? Can I get you something to eat? A lot of times when people are grieving or going through traumatic situations, they won't eat. They're just thinking about the situation at hand. So a lot of times at the other hospital I work at, we have what's called comfort carts. Call the kitchen, order a comfort cart. They send them coffee, cookies, snacks, water, and they put it in the room so the family can, get something to nourish them. Because a lot of times I've seen it, where a woman will stay by her husband's bedside for 6 hours and she never eats. So you got to think about these things. Bring them something to eat, and if you don't have a comfort cart, go in your own pocket and get them lunch. Whatever you have to do to help make that situation more palatable and comfortable for them. All right. Be genuine. I like this. I don't know what to say. If you don't know what to say, don't say anything. All right. Just say you're sorry. Tell them that you love them, that you're praying for them, that you're here for them. Don't think you have to know what to say, because you really don't know what to say. I know a lot of people think that when a person's grieving or suffering, that's the time to give them a sermonette. It's not. Now, I love to share the word of God. I love to give sermons. But when I'm with a patient that's sick or dying or traumatized, that's not the time for a sermon. Next. Avoid assumptions. Ask them how they feel. Don't assume how they feel. Sometimes you can walk into a situation and you think you know what's going on. No, ask. Unless you ask, you're not really going to know. And I use this example. When a doctor examines a person, a lot of times they'll ask you, where does it hurt? And when you tell them my shoulder hurts, the doctor will go over and touch it. And if the person twinges, yeah, okay, that's where it hurts. Same thing emotionally and spiritually. When a person is hurting on the inside, you ask them how they feel, and you'll find out, I feel hopeless. I feel lost. I feel suicidal. I feel like giving up. That's why it's important to ask, all right? Don't judge their feelings. If a person tells you they feel like killing themselves, don't think, I would never think like that. You don't know that. You may, if you went through what they went through, you might feel like killing yourself too. So be empathetic. Don't judge their feelings, all right? when it comes to the spiritual side of being a chaplain, ask permission to pray. Don't assume that they embrace spirituality and religion. Um, I'll share this real quick with you. I had a situation one time where I went to visit a patient. He was dying of cancer. He was in his 80s, but he had severe cancer. And he didn't have long to live. And when I walked into his room, I had on my clergy shirt, and he looked at me and said, "Nah, I don't believe in that stuff." And I said, "No, I'm not here to preach to you. I just came to see how you're doing." And so when I walked in, there was a baseball game on, and it was the Mets and the Phillies. And I said, "Oh, you like baseball?" And he said, "Yeah." And I said, "I'm a Mets fan. I'm sorry." And he laughed. And I said, so we started talking about baseball. I watched about 4 or 5 innings of baseball with this guy. We talked about the old days, back in the Phillies and the, Mets, back in the 60s and the 70s. And he had a lot of knowledge about baseball. So after about 4 or 5 innings of watching baseball with this guy, I said, "Well, sir, I'm going to see you later." And he grabbed me by my hand and said, "You can pray for me." And you don't know how that touched me. It touched me because I was there not to preach to him, but to be a friend, to share myself with him. And I think that alone let him realize, okay, I can trust this guy to share some spiritual insight with me, to pray for me. And that really touched me. A lot of times chaplains run in a room, say a prayer, they're out of there. No, spend time with the person, listen to them. Don't go in there, giving advice and spouting off, platitudes. Listen, pay attention. All right. Last thing, don't be overly touchy with strangers. Let them be the guide. A lot of times you have to be careful. I know I'm a person that likes to hug, but I have to be careful. If you don't think it's okay to hug a person, don't. If you get that feeling, but if a person looks like they need a hug, feel free to give them a hug. And if it seems like they don't want it, back up. Okay. Next. Okay. Recognizing PTSD. Now, I'm going to talk a little bit about my own personal experience with PTSD. I was in the military for 23 years, and I was in a combat mobility unit. And when I came back home, when I retired from the military, I was going through depression myself, not realizing that I had PTSD. And I went to CPE training, clinical pastoral education. I was in seminary. I was taking the psych rehab courses here at Ancora, and I'm preparing myself to become a chaplain. But as I started working on different cases involving traumatic situations, I started finding out I was having trouble dealing with it because of my own PTSD. And I didn't realize that I had PTSD until I went to a VA hospital psychiatrist, and he asked me a bunch of questions about my military career and my work as a chaplain. And of course, after about 20 questions, he said, "Yeah, you have PTSD." So when I run into somebody with PTSD, I'm very empathetic because I understand how debilitating it can be. All right. Depression, I've suffered from that. Sleep disturbances, I suffer from that now. Hyperactivity or hypervigilance. Hypervigilance is when a person that's especially been in combat, they won't run from a situation that's traumatic, they run to it because they've been trained to go after, to attack, to act, to interact. So that's a problem with a lot, especially military and police, law enforcement officers, EMTs. They're trained to be hyper vigilant. So it becomes almost like they can't help it. I'll give you an example. We had a situation at the hospital in Camden where it was an active shooter. Even though the person didn't have a gun out, they found the person was trying to sneak a gun in, so the active shooter alert went out. And whenever they give you an active shooter alert, they tell you, do not go to the area where the shooter is. I got up out in the on-call room. I ran right down to the emergency room, not thinking I shouldn't have done that. I should have avoided that, but I ran to it. And that's when a person with PTSD and hypervigilance, that's what they do. They run to the situation. Rage, outburst, road rage. That was one of the questions they asked me when they were trying to determine if I had PTSD. They said, "Do you have road rage?" And I say, "Yeah." In New Jersey, it's easy to have road rage. Okay, spontaneous crying. By the time that psychiatrist got through talking to me, I was crying. Thoughts of suicide or dying. Yes, I've had suicidal thoughts. And when a person has PTSD, they will have suicidal thoughts, because a lot of times nobody understands what they're going through. Why they can't sleep at night, why they're hypervigilant, why they, are overly cautious or maybe fearful about certain situations. I had a friend of mine that was a Vietnam vet. He heard a car backfire, he fell on the ground. That's what PTSD will do to you. Next slide. Okay, common causes. Of course, the most prominent common cause is combat exposure. But combat exposure is not the only thing that can cause PTSD. I was never in a direct combat environment. I was in combat mobility. My unit, we took troops into combat, equipment, weapons, things like that nature. But I saw things that traumatized me. Like when I was stationed in Dover Air Force Base, Delaware, the bodies from Guyana that Jim Jones had drank the poison came to Dover Air Force Base. Well, one of my jobs as an airfield manager was to help assist moving the bodies off the airplanes. All right. The whole base smelled like dead bodies. That was traumatic. All right. When I was stationed in Honduras, I saw a man accidentally get shot in the head. That was traumatic. I've had to go on recovery missions where we had to go look for bodies that from a helicopter crash in Korea. That was traumatic. So these are different things that happen. Now, at the time, I didn't think they were traumatic because I was just doing my job, but they will leave scars on you. Child abuse and neglect. I know working in the prison system and working here at a psych hospital, I say at least 50% of our patients were neglected or abused as children. So that kind of trauma can lead to mental instability, mental illness issues, okay? Alcoholism, drug abuse, terrorist attack. The people in New York City are still traumatized from 9/11, all right? Sexual or physical attack. A lot of the people that I encounter at the hospital, I'm also a domestic violence counselor. I've talked to women that have been abused and beaten by their husbands, all right? Those are some of the common causes. Serious accidents, car crashes, natural disasters, people that survived hurricanes, floods, earthquakes. Right now, there's a terrible earthquake in Turkey. I think over 15,000 people have died. That's going to cause some severe trauma for those poor people. And lastly, violent or unanticipated death of a loved one. That's one of the ones that we a lot of times overlook, because all of us at one time or another in our life are going to have to deal with the death of a loved one. And that's a traumatic situation, traumatic incident. And sometimes it leads to alcohol abuse, drug use, suicidal thoughts. So watch people that have gone through these different events. Next slide. PTSD affects many. Like I said, military veterans, a lot of people don't know this, but a fourth of the homeless men over 40 are veterans. A lot of Vietnam vets and Desert Storm vets, they're sleeping on the street because the war messed them up. All right. Unhoused people, homeless people, sleeping on the street. Those living in high crime areas. A lot of young people that live in cities like Camden and Philly, they've experienced more gunshot violence than some soldiers in the military. People in nursing homes and mental health facilities, I can attest to that. I've been working in Ancora 15 years, and I see how some of the patients that are chronic and have been in and out of this facility for years, they've been traumatized, sometimes by their own actions and sometimes, just by being at the hospital. Victims and witnesses of domestic violence, talked about that earlier. Domestic violence is a terrible tragedy, and from statistics, it's rising. Seems like whenever the economy gets worse and drugs get worse and alcoholism, everything, suicide, everything rises. Domestic violence is one of those things that rises too. And believe it or not, PTSD can affect children. I remember when I was asked about some of my experiences in life, the psychiatrist asked me, what was the most traumatic thing you remember as a child? And I can think of a few things, but I think for me, the most traumatic thing I remember seeing as a child was I saw a woman get raped when I was 10 years old. It happened right across the street from my house. And I didn't know what was going on. I went and got my mother. She grabbed me, covered my eyes, and ran me back upstairs. But I saw that, and that was something that traumatized me. And so a lot of times, you know, kids see things and they don't understand it, but it still traumatizes them. Next slide. Development of PTSD. Not everyone who experiences a negative life will develop PTSD. Some people have negative lives and they survive and they get through it without a lot of after effects. But these are the things that determine that, you know, intensity and duration. You know, maybe you were, you know, going through a hard time in your family and you didn't have lights in the house, or maybe you know, had to eat peanut butter and jelly sandwiches for 6 months until your dad got a good job. But at the time, you know, you got through it. But if that was more intense and of a longer duration, chances are you would have PTSD. Um, a lot of it depends on the injuries and the losses, depending on how severe your injuries were or how much you lost. Uh, Proximity to the event. I use 9/11 as an example. Uh, People that lived in New York City and lived near the World Trade Center, I'm sure those people are going to remember that for the rest of their life. It's some severe trauma. But maybe the people that weren't as close in proximity to the event, it wasn't as traumatic. All right. Sense of control. You know, one of the things about people that have been traumatized, you know, when you lose control, that's very traumatizing. You know, when you feel like you have no control over your situation, that can be traumatizing. And a lot of times, especially with people in the military, you know, you get sent somewhere, you know, you can't leave. You know, I was in Desert Storm. I was there for 6 months. I was in the desert. I couldn't leave. I was there 6 months. Had to deal with everything I had to deal with. I had no control over that. So that's one of the things. Post-event support. You know, a lot of it, a lot of people that have suffered from PTSD or traumatic situations, if they get support quickly, it helps them develop, it helps them to get through it better. You know, if they go to a psychiatrist or a counselor, or if they, you know, talk to their pastor or somebody they can relate to, a veterans group, something like that, it'll help. It helps to have support, somebody that went through what you're going through. That's why a lot of times veterans, they join the American Legion or the VFW so they can have some camaraderie and talk to other veterans about their situation. Next slide. Some risk factors for PTSD. Low socioeconomic status. A lot of times veterans, especially when they get back from the war, it's hard to find a job, especially if their only skill is to fight, to kill, to you know, to be involved in warfare. But that's why a lot of military guys, when they get out, they go into law enforcement, which is good and bad at the same time, because law enforcement is a lot like the military. You see tragedy, you see trauma, you see harsh situations, all right? Dangerous living environments. If you live in the inner city, especially somewhere like North Philly or, you know, Camden, you know, that's a risk factor, because a lot of times the trauma is right in your neighborhood. Senior citizens. I hate to say this, but when a senior citizen gets put in a nursing home, that's traumatic, especially when they don't have family and they're depending on a nurse or a tech or somebody to take care of them. And what if they got a mean nurse? They got to deal with that mean nurse until they die. That's traumatic. Exposure to domestic violence. Domestic violence is something that's horrible, because usually the woman that's being abused, she doesn't have a lot of options, you know, other than to just pack up and leave in the middle of the night. But still, she got to have some money. She has to have food. If there's kids involved, so it's never easy. And a lot of times, women that suffer from domestic violence issues, they don't feel comfortable talking to people about it, because a lot of times people judge them. Oh, you should just leave. You know, what if she's the only one, you know, taking care of the kids, and he's the breadwinner? It's not that easy. But there are agencies that will help that woman get free from the domestic violence. So point them to those agencies. There's 2 or 3 good agencies in Camden and Burlington County area that you can refer women that are involved in domestic violence to help them. Being female, sexual assault. Sexual assault is something that's not just limited to females, though. Men get sexually assaulted too, especially in prison. So if a person's a victim of sexual assault, it's going to affect them mentally, emotionally for the rest of their lives. I had a situation here at Ancora with a patient that refused to take a shower. And, you know, he was smelling pretty bad, but nobody would talk to him about it. So finally, I just went up to him and I said, you know, can I talk to you a minute? And he said, yeah, chaplain, what's up? I said, you were in prison, weren't you? And he said, yeah. And I said, were you ever attacked in prison? And he started crying. And he said, yeah, he was raped in prison. And it happened in the shower. So that's why the guy didn't want to take a shower. So I had to talk to the treatment team to get permission for him to shower alone and have somebody stand guard outside the door so he would feel safe taking a shower. Last thing, community violence. And we talked about that already. If you grew up in a bad neighborhood, uh, you know, chances are if you already have PTSD and you're living in a bad neighborhood, it's not good for you. And in fact, it may cause you to end up being if not a victim, maybe the perpetrator of a violent act dealing with your PTSD. Next slide. What can clergy do? Be present and empathetic. That's the number one thing. Be present and be empathetic. Don't be judgmental. Be empathetic. Put yourself in their shoes. You know, maybe you've never been beaten, raped, or assaulted, but how would you react if that was you? I remember one time in the emergency room at Cooper, there was a lady she was a rape victim, and they had her in the hall on a gurney. And I kept wondering why nobody was attending to her. And I said to one of the nurses, they didn't do a rape kit on her. The police could show up. And so one of the techs said, oh, she's a prostitute. That made me so angry because she was a prostitute, you're not going to treat her like she's truly a rape victim. So I went and got the social worker, talked to the social worker. They called the police. They did a rape kit. And, you know, she deserved to be treated like anybody else. So a lot of times clergy sometimes have to be advocates for the patient. You know, that's why I always say clergy and social workers need to work together. I always get to know the social workers, whatever hospital I work at, because a lot of times we have to work together. Network with other providers. That's the next thing. Network with social workers, psychologists, psychiatrists, HSs, you know, human services technicians. We work together because sometimes they see things you don't see, and sometimes clergy sees things that they don't see. A lot of times patients talk more to me than they will a psychologist. And a lot of times when they tell me things, I'll go I'll chart it, but I'll go talk to the psychologist and say, did you know that this patient is thinking about killing themselves? You know, so that's what we're here to do, help provide teamwork, you know, with the other providers. Last thing, partner with a diverse group of faith leaders. And this is something that chaplains have to, everybody can't be a chaplain because as a chaplain, you're going to work with people of other faiths. Now, I'm a Christian and, you know, I'm strong in my faith, but I have to work with other religions. A good example, about a month ago, there was a family, a lady committed suicide in front of her children. Half of her family was Muslim, the other half was Christian. I call him Muslim chaplain. We work together. And he ministered to them. The Muslims, I ministered to the Christians, and we got together. And we were hugging. I got coffee, got refreshments, but we worked as a team. And that's something you have to learn how to do when you're a chaplain. You can't be an island. You got to be willing to work with everybody, different faiths, different cultures. And but the bottom line is to help that patient recover. Next slide. All righty, discussion time. Anybody have any
Okay, so
questions
we
for
want
me?
to go ahead and open this up for any discussion. Tom, I wasn't sure if there was any questions in the chat.
Not yet.
Okay, so I actually have a question,
Okay.
Reverend Stevens. So considering your work as a mental health chaplain, how do you stay well and manage your own wellness so that you can pour out all that care and compassion and presence for other people, and prevent your own burnout? And I think that everybody, no matter what role they serve in mental health system, has probably struggled with burnout at some point. So what do you do for yourself?
It's not easy. And in fact, through COVID, it was pretty rough. Some of the things that we had to, deal with as chaplains. As chaplains during COVID, we had to spend about 90% of our time on the wards, and they closed the chapel, so we weren't able to do our religious functions. For me, it's gonna sound crazy, but sports is how I keep my sanity. I love the Eagles. I love the Sixers. I watch sports. I love art. I'm an artist. I love to draw. So I do things like that to kind of take my mind off of my own issues. And there's times when my own PTSD gets the best of me and I have to take a day off or two. But yeah, if you have to take a day off, take a day off, take a week off, whatever you have to do to get yourself together. Spend time with your family. My wife is great. She's very compassionate. And a lot of times when I'm having a hard time, she can tell I'm having a hard time. And but you got to sometimes get out of the batter's box and take a rest in the dugout.
And I liked what you said about if you don't love it anymore, it might be time to look for another career. And, not that somebody would make that quick exit, but you do have to, I think, constantly reevaluate, is my heart still in it?
Yeah.
And if not, can I get myself back to feeling good about my career? Or, am I at a point in my life where this isn't a great fit for me anymore?
Yeah.
Okay. Tom, do you have anything? Oh,
I do. I've had this question for years and years and years, and it's way off topic, but I'm just going to shoot it out. How do you approach working with patients whose illness is religiously involved?
that was one of my questions as
Right.
well.
I think it's a lot of people's question. I mean, I know it's a huge subject, but I'd love to hear what you think.
That's probably the hardest thing I have to deal with, because you don't want to diminish their thoughts and you don't want to diminish their beliefs, but sometimes their beliefs may be a little wacky. I hate to use that non-clinical word, but I remember when I first started in Ancora, I went to visit a patient and wanted to see a chaplain, and the first thing that the patient said to me, by the way, I'm Jesus. So, I just smiled, and I remember some of the things I learned in CPE and some of the other classes I took. I just smiled and I just nodded and I said, okay, well, tell me about yourself. We talked. I had to resist the urge to say, you're not Jesus, but I hung in there. But I think one of the problems with religion and mental illness is sometimes religion causes stigma. Like, for example, there's some churches that tell people that with mental illness that you're demon possessed. And that's just wrong. I try to explain to people, if a person can have a bad heart, you can have a bad brain. You need a doctor, you go to see a heart specialist. You need mental illness help, you go see a psychiatrist. So some of those stigmas cause people to either run from religion or try to embrace it to the point where they feel like only God can cure me. Not realizing that some of their issues stem from past traumas or stem from, I do a trauma group on Wednesdays, and one of the things that we talk about is, past hurts. And I have a patient that was telling me that he was, molested as a child, and just some of the things he went through. There's no wonder he had some of the issues he was going through. So, we have to be empathetic and we have to not judge them. I think the big thing is don't judge people. Just show concern and love, and if they want advice, give it to them. But if they don't want it, don't give it to them. But just be there to listen to their pain.
We have another question in the chat. Do you ever deal with staff going through issues and asking for help? What's your approach to this?
Oh yeah, at Cooper we had a team called a CERT team, crisis intervention team, and it was put together for staff, not for the patients, because a lot of times staff would see things and it would affect them. Like, I give you an example. I'll just share a quick one with you. About 6 years ago, there was a case in Camden. It was all over the newspaper about a young kid that got his throat cut. The kid jumped on somebody was trying to attack his sister. He jumped on the attacker's back and cut his throat, little kid's throat. I was working at Cooper that night. And when I got downstairs to trauma, I saw him as they were wheeling him in, and I saw the cut throat. And I froze, and my eyes immediately filled up with tears. And as they were rolling him into trauma, half the trauma staff was crying. You know, the kid was already gone. He died. And we had to have meetings, the staff, how do we get through this? Because it just messed me up. And that was about maybe 6 months before I got diagnosed with PTSD. So you have to talk to people. You know, if you don't find somebody to talk to, somebody that'll listen to you, because that same night there was a police officer that responded to that case, a rookie police officer. He was crying, and I talked to him. And a few months later, there was another situation in Camden where a lady was smoking wet, you know, methamphetamines. She cut her baby's head off and put it in the freezer. This police officer responded to that one as well. He quit the police force after that. He said, I can't take this anymore. I was ready to quit myself after that one, you know. So, you know, I kind of got a little bit of vacation during COVID, because for a year and a half, they didn't allow chaplains to visit patients during COVID. So I was away from Cooper for a year and a half. So that was a little bit of a break, but I didn't get a break in Ancora.
Ancora will always keep you busy, right?
Yeah.
If it's not with patients, it's with the utility outage.
Yeah.
Here's another question. Do you know why so many psychiatric patients have a religious preoccupation?
Like I said, I think a lot of it comes from their upbringing. I'll give you an example. I don't want to pick on any religion, because all religions have their good points and bad points. But say, for example, you were in a very legalistic religion that taught you, or they talked about certain things. Like, I'll give you an example. I got a patient I'm dealing with now. His whole conversation is about the end of the world. And his denomination, that's one of their main thrusts, to talk about the end of the world. So if he was raised that way, he has mental illness, and he just overemphasizes that particular topic. Then you have some patients that are very anti-religious because of what the stigma that they endured in church. So that's why I try to be, I tell people all the time, I'm not a religious chaplain. I try to be spiritual. I try to listen to people. I try not to judge people. I try not to sermonize people. I try to love people. I try to let people know I'm there for them, you know. And I tell people that I'm trying my best to be like Christ. I want to love you. I want to understand what you're going through. I'm not here to judge you. I'm here to help you.
I think what you also said was really interesting, and I never thought about it that way. This idea that people might, if they think that their mind is somehow defective, or if they buy into the belief that there might be demonic possession or something impure about them, or that maybe they had sinned and that's what's causing the distress that they're having, they might run towards that religion and try to embrace it more, or on the other hand, might push it away, right? So I think that was a really interesting take, and something I had never considered before. And yeah, I appreciate that insight. Is there anything else in the chat, Tom? I wasn't sure.
No, not at this time.
Okay.
I did put up the IPR website. Encourage you to go check that out.
Okay. Would you like me to go to the website or anything? All right.
Well, you can show people that we've recently redid the website. So now we're the Institute for Inpatient Psychiatric Rehabilitation, and we're taking a national perspective on issues related to inpatient psych rehab.
Yeah, let me share that a little bit. If I can get back to Zoom.
No Zoom.
So for those of you who maybe haven't been to our website in a little while, you may notice it looks a little bit different. So we just wanted to take the last, few minutes of the time that we had in the webinar just to kind of show you that we have rebranded, so to speak. It sounds really funny saying that, but we are no longer the State Hospital Psychiatric Rehabilitation Initiative. We are the Institute for Inpatient Psychiatric Rehabilitation, because I think we've been around far too long for it just to be an initiative anymore. So that is the big news here. So just want to show you that there are still, when you click on free online trainings, you can still access the tons and tons and tons of videos here. which are mostly, and I think he might be on right now, mostly attributed and authored by Ken Kinter. So there's still that slew of free trainings. It just looks different. We're trying to make it look, yes, Tom.
Oh, I just want to shoot one more question while we have Pastor Stevens. It says, what do you do when a patient's spirituality might cause them to bypass their traumatic experience? Interesting question.
Yeah, that's a good question. Sometimes I've had patients that, for example, they'll say, well, I don't have a psychiatric problem. I don't have I'm not mentally ill. And I don't want to, get into an argument with them about their condition. But what I do say to them, like I said before, when you have an upset stomach, you go see a doctor. When you got a headache, you go see a doctor. But so if you're having emotional issues, go talk to somebody. My biggest probably fight with patients is they're quick to tell me I don't want to take medication. Yeah. And I try my best not to contradict the doctors and the medical staff by saying, no, I agree with you. I just say, well, the doctor's here to help you. That's what I try to let them know. And they care about you. They want to do what's best for you. And sometimes I'll remind them, well, what brought you here? And they'll say, I stopped taking my medication. Okay. So
funny how that works.
Yeah.
Okay.
By the way, I just want to, Ken Kinter was my instructor for psych rehab, and I learned a lot from him.
He's a big fan of yours too. He's what got you into this.
Yeah.
Speaking.
Thank you, Ken.
And I'm going to click right here on the prep webinar series tab you see. So that's also where we're going to be posting our upcoming webinars. Reverend Stevens, obviously covered his webinar today. So sometime later today or tomorrow, that webinar will also be available on our website. So one other little spot here. The Rutgers DBHS Continuing Education tab is where all of our online interactive courses will appear. So you'll start to see primarily those courses that are courses related to the clinical formulary. So like IMR, social skills training. We even added safe wards here, even though that's not a curriculum or part of the clinical formulary. But there's a slew of trainings that are here now, about 6, maybe I shouldn't say a slew. In addition to a set of trainings that were originally produced by Palo Alto University for Anne Klein, I believe, but around competency restoration, and they're available to all as well. Tom, is there anything else you want to say about?
No, just that people loved your presentation, and they have all kinds of good things to say about you. I don't know if you're paying people or what's going on, but.
Well, it was my pleasure. I enjoyed it, guys.
Thank you. So with that, I guess we'll go ahead and wrap up. Tom, did you put the training eval? Oh, there it is. So Tom just put the link to our website in the chat. Tom, did you also drop the training eval?
I just did.
That's the website.
Okay, fine. I just did.
All right. So Tom just dropped that red cap link in there. That's the link to the training evaluation. And when you complete that training evaluation, you'll also be able to download Reverend Stevens' PowerPoint. And that's all we got. So thank you so much. We'll see you all back here next month. Bye, all.